Good afternoon, everybody. Welcome to this symposium sponsored by Elixir Medical, Cracking the Calcium Code, Novelty and Utility of Hertz Contact, Intravascular Lithotripsy. We have a packed room, so this is good. There's a lot of interest. My name is Stefan Verhey from Antwerp, Belgium, and I'm co-chairing with Valeria Paradis from the Netherlands. We have a wonderful panel with Roxana Miran from the US, Stefano Galli from Italy, and Johanna Bennett from Leuven, Belgium. So, having said that, we'll introduce the session objectives. So first of all, it's really we are dealing here with a new technology. It's a very hot topic. We all want to do something to the calcium that we are facing in our daily practice, and so we want to engage in a discussion on the current unmet needs today in calcified lesions. We really want to learn about this new technology, which is called the LithiX HCIVL system, and we will dive into the mechanism of action. And obviously, we will share some cases and show you how this balloon works. So really, it's on introduction and focusing on the LithiX balloon, and have a didactic review of the cases from the Pinnacle 1 study, which you will hear more about today and also tomorrow when the results are being announced. So now I would like to ask Valeria to come to the podium and share us everything about the new technology, the new balloon, and the mechanism of action. Valeria, please.
Good afternoon, everyone. So let's try to understand what's the mechanism of this new device, intravascular lithotripsy device, Hertz wants to, what does it mean? So lithotripsy, you know, comes from Greek and means breaking stones, lithotripso. But the concept behind this new device, the Hertz contact device, was to achieve something which was a device able to be safe, to be effective and uniform via a discrete amplification of force throughout the calcium, to be something which could be easily integrated in the PCI procedure workflow with a low crossing profile, with a very good deliverability, and effective across complex calcium morphologies, meaning eccentric, concentric, nodular. But before describing the technology, let's go to some basics. Let's go to physics principle of Hertz contact. What does that mean? So basically, we talk about the Hertz contact physics phenomenon when we apply force, and the force we apply with a curved sphere getting contact with a plane surface. In this equation, there will be some variables which come in, and these are the contact force, of course, the force we apply, the module of elasticity of both the tissue, the area of contact, and the radius of both the curvatures. So, meaning that when we have a high modulus of elasticity, for example, the calcium and a small contact area between the two surfaces, then the device goes really hard. When we have a low modulus of elasticity and a large contact area, then we have the device which goes really soft on tissue. This technology is a semi-compliant balloon with the small metal hemispheres incorporated on that along the whole surface of the semi-compliant balloon. The small hemisphere will apply this contact, this force at the level of the contact points, and then amplify this force along the whole calcium distribution. In this way, we'll have a multitude of calcium fractures. And here I want to show you how hard the device goes on calcium. You can see here in red that the contact stress is really high, from 60 to 80 atmosphere when the device applies to calcium, and it goes really soft on tissue. Some characteristics of the device: the diameter ranges between 1.5 to 3.75. The entry profile is really low, lower than 1 millimeter, and the working range is between 5 and 12 atmosphere. And this is a video from a bench model testing showing how the device applies and the force applies and propagates along a concentric calcific module. We have excellent safety profile in porcine preclinical studies of this device. You can see here some nice OCT imaging comparing the LithiX device and the control device. And you see here really clearly and nicely that the injury caused by the LithiX device is really minor, and you see a nice intramedial dissection on OCT caused by the plain balloon. But also the effectiveness of these devices compared to the control group is really remarkable, with a percentage of area of stenosis particularly significantly lower with LithiX device. So I have the pleasure to introduce you the first trial which assessed in man the use and effectiveness of this device, the Pinnacle first. The study objective of the trial was to assess the safety and performance of the LithiX coronary intravascular lithotripsy catheter to treat moderate to severe calcified coronary artery. 60 patients were enrolled in 7 clinical sites in Belgium and in the Netherlands. The patient had to have at least up to de novo coronary artery lesion with moderate to severe calcification, with the reference vessel diameters between 2.25 and 3.5, lesion length lower or equal to 34 millimeter to be enrolled in the study. We also had an imaging subgroup in 32 patients where all the patients undergo OCT, a pre-procedure, post-LithiX treatment, a post-stent implantation. The objectives were to assess the effectiveness and safety endpoints, so residual stenosis lower than 50% with no hospital MACE through the hospital discharge, and the safety endpoint of MACE up to 30 days. Then we'll have a clinical follow-up at 6 months. These are the patient baseline characteristics with an average age of 72, 65% of male enrolled, 30% of diabetic patients, 50% with renal insufficiency, 80% with stable angina. For the baseline lesion characteristics, I want to underline the fact that 80% of the lesions were considered complex according to the ACC lesion classification. Reference vessel diameter was 2.79. Calcified length was 21 millimeter. And when we look at the data from the OCT imaging subgroup analysis, well, we see that the extensions of the calcific plaque was particularly relevant. And we have here that the calcium arch was more than 3 quadrants, almost concentric calcium. And we also identified 31% of patients presenting calcific nodules. You have some on the right side of the screen, some nice OCT imaging showing the calcium distribution, eccentric but also concentric, really thick, more than 1 millimeter. And also on the bottom right, you see a calcific nodule. And when we used the device, the calcium fractures was possible and visible at OCT in 90% of the lesion, with at least 1 fracture, and up to true fracture in 37% of the patients. The stent expansion at the minimal stent area was particularly impressive. You can see here that the area of stenosis decreased from 50% to 14% at the level of minimal stent area. And the stent expansion, that's remarkable, 90-70%, just to compare what the achievement, what the goal of the consensus document from EuroPCR is 90%, so really important in calcific lesion. So I want to conclude saying that LithiX Hertz device is designed to treat a broad range of moderate to severe calcific lesion, is safe. It can be easily incorporated in the PCI workflow, but I will invite you to join the session tomorrow afternoon, Thursday, where we will discuss the results of the main trial.
Thank you, Valeria. You already gave away a lot of the outcome. Of course, the primary endpoint we cannot share today. That's why you have to come tomorrow, where you are invited. But of course, you already have seen a lot of the data, and you already have seen that the fractures that you see that you obtain with the simple balloon is actually very impressive. Again, over 90% of fractures in all cases. So what I'm going to do is we'll show two cases. I will share a case, and then Johan will also share another case. This is a 65-year-old male, classic risk factors. He had an atypical finding on the stress test. We performed a CT scan where we saw a lot of calcium present. He had also angina, and then so therefore he was submitted to undergo a coronary angiography. So there was on CT scan an extremely calcified lesion of the proximal and mid-LED causing this significant lesion. As you can appreciate here, there was a sharp takeoff from the LED out of the left main. And you appreciate with me on the left side, there's an abundance of calcium, also blooming effect of the calcium on CT scan. You'll appreciate here the lesion at the mid-LED just after the diagonal, but I think there is a subtotal lesion on the proximal LED, and when you perform OCT scan, again you will see this is the left main we're looking at. As soon as you enter the LED, you will see a lot of calcium with a tight lesion in the proximal part, getting a little bit larger, but then again coming to the side branch, and again you see the calcium and the plaque sitting there. Again, just distal to the diagonal, there's a lot of calcium, and then the disease stops, as expected also on the CT scan, to become a somewhat to say normal vessel again. So what we did, the protocol mandated to first go with a normal balloon, which we did. We used a 2.515. We took it up to 12 atmosphere just to see what happens, and basically as expected, or at least maybe not expected, but it didn't do much at all to the lesion. So you don't see a lot of modification to the plaque. You don't see any fracture to the calcium. The intima is still preserved. There's no tearing, and you basically end up with the sort of same lesion that you started off with. So that's what we usually do with a non-compliant balloon. You think that you modify the plaque, but you basically don't. We used a 2.514 LithiX balloon, which was very easy to enter. So once again, you take another balloon. One of the advantages is you don't need capital equipment. You don't need an external source. You just take a balloon from the shelf. But of course, it was one of the cases the first cases that we did. We didn't feel, we didn't know what to expect. And you can actually see when you look at the balloon on the still frame. I hope you can appreciate it. There's little dots, and those are the hemispheres that Valeria pointed out. But immediately you can see you got a significant tearing and fracture at the level of the proximal LED into the calcium. And that's already a very first step. We were very gentle. We used a 2.5, and we were able to modify the plaque already, causing a fracture just with this balloon. So what we then did, we took a larger balloon, a 3.5. The intention is actually to use a 1-to-1 to the reference vessel diameter. And so again, we were able to position very easily to get the balloon into the lesion, took it up to nominal pressure is 5, but we went up to 12 atmospheres. And on the angiogram, maybe, you know, it's maybe hard to say, but there is some more opening. But especially when you do the OCT run, you will appreciate with me you got a significant tearing and fracture at several sites along the lesion, also mini fractures, as you can see, into the calcium. So of a significant width and depth of that is meaningful, which allows, of course, the stent to expand because you crack the calcium. So this is the OCT outcome after LithiX. We then took a 4028 DES at the proximal LED, covered it with the mid LED just after the diagonal, and this is the result we obtained after stenting. We did, again, an additional non-compliant balloon, 40, took it up to 16 atmosphere, and actually ended up with a nice final angiographic result. So this case, I think, clearly demonstrates that by using this LithiX balloon, and this is just the final OCT, we did have some malapposition at the proximal part of the stent was in the distal part of the left main. But overall, you have good apposition here and there, some malapposition, but basically clinically not significant. And a good expansion, as you could see from the data shared by Valeria. We actually obtained a significant stent expansion. If you look at the sites of the maximum calcium, you get over 100% stent expansion. If you look at the minimal lumen site, minimal lumen area, you get a stent expansion over 100. And at the minimum stent area, you get up to 96%, which is really hard to beat. The radiation dose, 895 milligray, fluoroscopy time, 10 minutes. Total amount of contrast, 180 mil, right radial, 6 French. Needless to say, very easy procedure, simple, straightforward. You can use multiple if you need to. So in other words, it was one of the first cases that we did. We were dealing with an extremely calcified lesion on the proximal and mid LAD. It was a successful. It's basically no learning curve. It's just another balloon, so to say. But of course, it's a special one. It has several hemispheres, and it was able to deal with the calcium and to deal with the plaque preparation, causing multiple calcium cracks, allowing the stent to for a full expansion. And basically, that's what the patient needs. He doesn't care where there's a lot of fractures. He needs to have a stent that is well expanded and opposed to the vessel wall. So I think this case, and we'll learn more from Johann's case, but I think we should discuss maybe a couple of minutes before we go to the next case.
I'll use this. Congratulations on that case, and really a very nice demonstration of this novel balloon catheter that I think has a low profile, capable of dealing with this significant length of calcium in a tapering vessel, which is often something we get very worried about. What I was really impressed by is the fact that while you crack the calcium using two different sizes of the balloon, that I didn't see any flow limiting dissection. And that to me is what is one of the issues of the current technologies we have available, forcing us for, definitely putting a stent into, and I often think about, can this technology be paired with drug-coated balloon in diffuse, small, calcific lesions to be able to not only get a really good, of course, for this proximal vessel, I 100% agree that we should be using a stent, but I'm thinking that it could really be a great paired up technology with also drug-coated balloons, because I think with drug-coated balloons, we absolutely need to get the drug into the, layers, the vessel wall, and we absolutely need to crack the code. There's no question about it. But without making flow-limiting dissections. Can you tell me a little bit about, I know maybe you can't say anything about Pinnacle 1, but just your own experience using this particular device. Are you impressed with that? Is that something that you would say is different than what you've been used to before?
Roxanne, I think you raise a very important point here. When you use other balloons to sort of open the calcium, you deal with, there's a high chance that you will have a significant dissection. And it's going to be longitudinal dissections. And we, initially, like I said, we were very careful. We used smaller balloon sizes, but then along the way, along the course of the trial, we actually went to a 1:1 reference vessel diameter size, which was able to actually get the balloon easy into the lesion. It's deliverable, it's trackable, and there's enough push to get through that lesion. So I was very pleased with the performance of the balloon. And of course, once again, I can't say whether it's safe or not, but that's only for tomorrow. But it actually does the job, what it needs to do. And coming back to the point of the dissection, what we see is if you have a dissection, it's a radial dissection. Mm-hmm. It's not something that goes retrograde or progressively or antegrade. It just stays there. And the dissection is not really deep into the tissue. It actually breaks the calcium. As you can see, the total depth of the fracture that you cause is around 0.8 to 0.9 millimeters with a small width. And I think that's, in terms of trackability and performance, it's actually very easy to do. And again, like I said, it breaks the calcium and it allows you to put a stent and open the vessel. But again, we have Valeria, we have Johan here who have used the balloon, so I would love to hear their opinion.
So, and a question and impressive. If I understand well, this technology, Hertz technology, is a multiplicative of pressure. Normally we use 12 atmospheres, but against the calcium, against the wall, we reach 90, 100 atmosphere. Is very high. Regarding this point, there is some tip and tricks regarding the movement of the balloon, or use in terms of a little bit torque to cover it with the micro hemispheres every square of the plaque, or you just inflate like another balloon, first. And second, in this particular case, that the OCT that we see, I agree that if you appreciate where the depth of calcium is high, we don't see a big crack inside to the calcium, but we see the crack, radial crack at the end, near to the vessel and the calcium. This is a particularity of this balloon or this technology, or is a case?
Well, I would like to answer particularly the first question, because I think we have to really underline this technology, because the presence of multiple hemispheres, so we apply force at multiple points, contact points, and then it will propagate along the surface, means that we don't really have to be worried in which position we inflate the balloon. While when we have blades with other technique, then it's just a matter of chance, either we tackle the calcium or not. So that's the first thing, and we have maybe to rotate the balloon and reinflate the balloon with other technologies, hoping that eventually we will tackle the calcium. In this case, like when we size 1:1, we are sure that we will be effective.
Perfect.
Yeah, and I would like to add also once more, in all the cases that we've done, we have not seen any balloon rupture at all.
Absolutely.
So you go to nominals 5, you can take it up to 12, which all of us have done. And despite the fact that there's lots of calcium there, and you end up with looking at the OCT with more than 90% fractures in all cases, you don't see a single rupture of the balloon. Yeah. So I think that's very impressive. Yeah. But I think we have to move on for the sake of time. So I would like to invite Johan to show and share his case. Johan, please.
So good afternoon. It's a real pleasure to be able to present this case of Hertz Contact intravascular lithotripsy. So this patient indeed was enrolled as well in the Pinnacle 1 first-in-man study. The patient is a 71-year-old female with new onset exertional angina, former smoker, hyperlipidemia, and a strong family history of ischemic heart disease. She has COPD and actually has stable in remission metastatic melanoma and also multiple myeloma requiring a bone marrow transplant a number of years ago. So normal ejection fraction and no structural heart disease. So this is a small lady with no radial access, so hence the femoral access for this case. But I think you can appreciate quite clearly in LAO and RAO the severely calcified lesion in the mid-RCA. Before the contrast comes in, I would suggest a severe calcium present there in this lady. The plan was to perform upfront OCT imaging, but as you can see on the left image here, the catheter, as happens in real life as well, doesn't always want to follow the tortuous or calcified vessel. So we did some pre-dilatation with a 2.0 balloon, semi-compliant there, just to enable to pass the OCT catheter. This is the pillback from the core lab. So as it comes back from distal to proximal, you'll see areas of calcium highlighted. So here we come back from distal, and you can see in certain points the depth of the calcium, the arc of the calcium, and different features that we want to look at. So again, diffusely diseased vessel of calcium, not circumferential, but quite a large arc of calcium. If we look a bit more detail at this OCT pillback, we can see here in the longitudinal view in the middle panel, there's a bit of a protrusion there of calcium, which is obvious in the lower panels, the lower 3 panels, where you can see this thick calcium, very eccentric, with some protrusion into the lumen. And above panels, you can appreciate there's calcium in the mid-above panel, an arc of perhaps up to 180 degrees. So when we analyze this case in more detail, we could suggest there's probably 3 calcium plaques in this vessel. At this level, of course, the mid-RCA. The total length was about 24 millimeters. The maximum calcium angle was 196 degrees. The average thickness was 0.79, with a maximum thickness of 1.23 millimeters. As I mentioned, there was a calcified nodule present as well, and it gave us an OCT score of calcium of 3. So we then proceeded with a 2.5 millimeter 14 LithiX. So we brought it up to, as in all cases, up to 6 slowly, and then up to 12, and we kept it at 12 atmospheres for approximately 30 seconds, unless the patient, of course, had complaints, but that actually never did occur. So I think we can see here with the 2.5, we get a nice opening of the balloon. There's a bit of a bend in the proximal right, but apart from that, there's nice expansion of this balloon. We then moved on to the 3.0 LithiX, based upon the OCT diameters we got. And again here, up to 12 atmospheres, number of inflations, taking your time to ensure a really good apposition, or expansion, sorry. So this is the OCT then after the 2.5 and 3.0 LithiX. I think you can appreciate in all panels there is dissection present, which angiographically was not really visible. And especially I can draw your attention to the top right panel, where we can see a really deep crack in that kind of protruding calcified nodule eccentric calcium plaque. And again, on the other side, is this dissection. So as per all cases, if I use rotoablation or lithotripsy or shockwave, we use an NC balloon to really do optimal predilatation before implanting a stent. So that was performed to get the maximum effect. 3.026 DES and proximal 3.5 DES were implanted with a nice result angiographically in LAO and RAO. And then, of course, then we did the OCT analysis. Again, this is from distal to proximal. So I think you can appreciate, although the pillback quality is not extremely good, you can appreciate that there is a good result on OCT. So this is the distal RV branch coming in. And as we come proximally, we can see a nice expansion, apposition of the struts. Obviously, there's still calcium present, but it's behind the struts of the wall. I think the stent expansion in this case was approximately 90% when measured in the core lab. As you can see here, coming more proximally, there's some minimal protrusion of that nodule, which of course we know can be difficult to treat. becoming proximally, there's good expansion, a nice large vessel, and a nice result with no proximal or distal edge dissection present. Also on the longitudinal view, we can see really nice expansion of this stent with a nice result. So in conclusion, this was a 71-year-old lady with new onset angina, severely calcified right coronary artery with a protruding calcified nodule. The LithiX balloon caused multiple calcium cracks with excellent lesion and plaque preparation. Expansion was excellent on angiography and OCT. And at present, we're actually almost now 9 months on, she remains asymptomatic. Thank you very much for your attention.
We have a question.
Yes, may I see again the image of the predilatation with this balloon, please? May I see of this presentation? I saw maybe 2 wires at some point. There was some problem of pushability or support body wire or a risk of collapse of internal lumen with high pressure.
You're correct. You're very well spotted. There were 2 wires. As you know, these right coronary arteries can be a bit difficult. So even getting the OCT catheter down was a bit difficult. So therefore, I decided to put a second wire down. So you're right. There's 2 wires there. I wonder where it comes in really to get the stent in position. I think really was to get the 2 wires down. So yeah, you're right. But no other reason than that. No special reason.
But John, honestly speaking, I appreciate that to advance the stent, probably you use a probing catheter that don't you use for the advanced
a guide extension.
No?
Yeah.
Sometimes if you use a bigger other lithotripsy catheter, sometimes we need to support to advance it. So in this case, performed very well.
Yeah, I mean, obviously, it is not a 1.0 sapphire balloon. You know, it's a crack the calcium. It has a bit of a profile, but it's very deliverable compared to other things out there, I believe. So, but yeah, you have to be prepared. Get it extra supported. There was an AR2 guiding, 6 French. But even with that, it didn't had loads of support with the guiding. So I think you want to prepare for success. So you make sure you have enough support there with a wire or extension catheter.
I just had a mechanistic question. Does your lithotripters produce the same shock wave as the shock wave balloon, the positive wave and the negative tensile? Completely different physics?
Yeah.
It's completely different.
Different physics.
The physics is completely different, as shared by Valeria. It's called the Hertz Lithotripsy Contact. So it's all based on tensile stresses.
Just tensile stress. It's not
tensile
positive.
stresses, and they are amplified by a series of parameters. And the amplification, for instance, if you have a high modulus of elasticity of the curved sphere that comes in contact with an object that is inelastic, then you will get a crack. And basically that's what happens. So it's hard on calcium, but soft on tissue.
One question. In these cases, I used to use a short balloon, non-compliant, not 12, 20, 22, 25 atmospheres, and praying not to get a dissection. So what you are telling us is that with this technology, can we get similar results with much lower pressure?
That's the story. Basically, forget your old technique and use this one. You use one balloon, go to low pressures, and crack the calcium.
It's enough, only 5 or 6 atmospheres to crack such.
Well, it's nominal at 5,
12,
but most of us have taken up to
12 atmospheres.
12
mainly,
atmospheres.
12, I think he put.
And the balloon has a low profile, meaning that you not necessarily have to go with a 1.5 first. You can actually go with a 1-to-1 reference vessel diameter because it has a low profile. So that's one of the other advantages.
Thank you.
The question, does it work with completely circumferential calcium? Do you have any data?
Yeah.
Well, yeah, I mean, I guess we're still looking at all the results,
first case.
evaluations. I mean, I think the first case, maybe it wasn't 360 degrees, but it was certainly a large arc of calcium.
Yeah, so the answer is yes, based on the OCT core lab analysis. It works in concentric, eccentric, and calcified nodule. And calcified nodule was present in 30%, as shown by Valeria, in our series. Of course, we're talking about 60 patients. It's a first in man, and 32 patients underwent OCT. But the data were very convincing about all of that.
So,
And what do you do if the profile doesn't cross with the regular balloon? It's excluded?
You mean with a regular balloon, like a 1.5?
Yeah.
Most of the lesions, I mean, we were able to cross all lesions.
Okay. But if it doesn't cross, you exclude those patients.
If in part of the trial they were excluded, yeah. If you can't cross with a, but like I said at the beginning, we actually used a normal PDCA balloon or a non-compliant balloon. But later on, as the study went by, we actually switched to a LithiX balloon for the first attempt.
Okay.
Stefan, in the future, in the real world, I imagine that we don't use one balloon. Probably the LithiX treatment could be step 1. I don't know if 1.5 or 2.2, and then so to use 1 or 2 or 3 of this balloon is possible or
that would
not?
be a cost prohibitive, no? I think.
Yeah, you can do that. And I think, once again, at the beginning of the trial, we were very cautious and we were, using a small size balloon. But again, as time went by, we just switched to a larger balloon and forgot about the 1.5.
Yeah, absolutely.
Because of the low profile, because of the deliverability, and the performance of the balloon, basically.
I'm actually fascinated by this particular case with a calcific nodule and then some circumferential nodule. And when I see that, we're often a little bit nervous about, the dilatation and all of that. And here you showed that you were able to do this. I know you can't tell us about CKMB elevations and things like this, but I think this is a really, really important piece that there is, it seems to me that maybe it doesn't matter what kind of a calcific deposition you have, that the balloon is sort of all things to all calcific patterns. Now, I don't know, we'll have to see. Only half of your patients had OCT, of which you had a third of them, 10 of them, I think, or 9 of them who had calcific nodules. But I think that is a really, really important piece in terms of better understanding, especially when the calcific phenotype is one of mixed, because you don't want to be using 2 different devices, and it seems like this particular device takes care of both. Is that a...
Yeah, absolutely. I think that's the promising aspect about this, is these nodules. I think in the 15 cases I did, there were a number of nodules that were nicely modified. So, of course, 60 patients we have to see, but I think the initial experience is very encouraging.
And you didn't know what you were getting, right? I mean, you went in and half of them didn't even have imaging, and you were able to get through. The half that you did, a third had calcific nodules. So I'm really, that to me is a very important takeaway. So it is really interesting. Thanks.
Are there any other? Please take a microphone.
Did you test this balloon in more tortuous coronary segment?
Yeah.
Because sometimes with the other similar
Devices,
balloon,
yeah.
it's difficult to reach the lesion.
Yeah, of course. I mean, for us interventional cardiologists, tortuosity and calcium are our enemies. So I think, yes, I certainly did use it in some tortuous vessels needing, guide support, guide extension support. So the ones I treated, I was able to treat. I'm not sure about you, Stefan, your experience. Of course, this is a first in man, so we probably didn't push the boundaries as you probably don't usually do with these newer devices. But in the ones I did treat, I had good results.
Yeah, and I think, once again, just reiterating what Johan just said, is in tortuous lesions. I remember, and Stefano, you were visiting us when we did a challenging circumflex case where you said this is not going to work, but we managed to get the LithiX balloon there in a sharp takeoff of the circumflex. And in another case, you get there with the LithiX balloon and you try to put the stent, and the stent doesn't go. And so just illustrating that the balloon actually really performs very well in tortuous calcified lesions and tight lesions too.
I believe it is very important because this lithotripsy therapies, the other competitor, unfortunately, at the moment, the profile and the crossability is not so high and not comparable with this standard NC balloon.
So when will we see this in the U.S.? Who could answer that? Because we certainly need the competition.
Somebody from Elixir here?
Well, I want to thank you very much for today. We are pursuing this aggressively, so we will be filing with FDA for a trial that we anticipate to begin at the end of the year, and we anticipate it to be CE mark approved also by end of the year.
So I think, as I said in the beginning, it's a short session, only 45 minutes.
But we cracked the code.
We'll actually, well, thank you for coming. That's it. We can crack the code. I just want to conclude the session. I really want to thank the panel. I want to thank you for coming and for listening to what we have shared. So I think clearly the unmet needs in coronary artery calcifications, we need a simpler procedural workflow. We are aware of all other devices who have external sources or capital equipment that is required to do the cases, and sometimes ad hoc doing these cases not always that straightforward. Now, having a tool that is available on the shelf, just with the same performance as any other balloon, where you're able to just treat all the calcified lesions, moderate, severe, even maybe mild lesions. Remember, it's hard on calcium, soft on tissue. And I think this allows you to, like I said, ultimately what matters is the stent expansion for the patient. He doesn't care whether there's a lot of calcium or not, but he needs to have a stent that is widely open and have no angina anymore. So we all know that lesions are difficult to treat. So I think the LithiX Hertz Contact Lithotripsy is a novel design, and it's a new mechanism of action offering a safe, effective, and simplified workflow. As you can see from the results from the OCT, that we have an incredible high percentage of calcium fractures. Only one fracture maybe in 15% of the cases, but more than 2 in 75% of the cases. So that's really a high number. Obtaining then finally a stent expansion at the minimum stent area of 96%, which is almost inachievable if you look at the EuroPCR guidelines. So once again, thank you for coming. I would like to thank the panel for discussion and for sharing their insights. And I would like to invite you to attend the session tomorrow for the complete results. Thank you once again.
Can you tell us the room and the time for tomorrow?
It's on the screen, Roxana.
Oh, thank you.
It's at
3:52.
Yeah, and it's not going to take an hour and a half, but somewhere in between.
Okay, that's good.
Thank you for coming.
Thank you.